Good afternoon, everybody. I'm Jim Erickson with Monteris Medical. I am the CFO and head of our marketing group, and we are very honored this afternoon to have this distinguished panel of speakers with us. This afternoon with us is Drs. James Rutka and Drs. James Drake, both from the Hospital of Sick Children in Toronto. Also, Dr. Matthew Smyth from Washington University in St. Louis, and Dr. Taylor Abel from the University of Pittsburgh School of Medicine. We're really honored. We've got some great content on this topic of laser ablation for pediatric epilepsy and oncology. It's been a real privilege for us here at Monteris to partner with each one of these institutions and users as they've evolved their programs in laser ablation, and we're really excited to listen to the experiences they have to share this evening. So just a quick bit of housekeeping. Well, we do want to have some time for question and answers tonight. You should be able to do this in two methods. On your control screen, you can either click to raise your hand, and when you do that, if we've got some time, we'll call on some people to ask questions. Mute yourself first, and then we'll ask you to unmute if you've got your hand raised. Or there should be a Q&A section where you can type in your question and answers, and we'll try to hit as many of those questions as we can along the way. So with that, Keith, if you want to, we'll hit the two disclosures here for our, each is obviously a consultant with Monteris as they're helping us out this evening and elsewhere. And then one more, this is our standard Monteris disclosure around the technology, the limitations of the technologies, and of course the risks that are associated with brain surgery that will be talked about tonight. So with that, without further ado, I'll turn it over Dr. Rutka and allow you to kick us off this evening.
Great. Thanks very much, Jim. And thanks to everyone who's attending this webinar this evening. Thanks to my colleagues, Dr. Drake, with whom I have worked the past 40 years, and Matt Smyth, whom I've known also for many, many years, and who serves currently on the Journal of Neurosurgery with me, and Taylor Abel, who trained at the Hospital for Sick Children not too long ago. So really looking forward to hearing their presentations as well. Okay, so I'm going to present our experience in part. Dr. Drake will follow up with his presentation from Sick Kids. We're fairly new adapters of the technology. However, I would say that over the last 4 or 5 years now, we've been able to advance our technologies with laser ablation, and I'll discuss our experience. So you all know this is MR-guided therapy. There are different ways to use the laser probe, whether frameless or frame-based. Experience in children is perhaps a little bit less than in adults, where it's used a lot in the realm of oncology. And for children, in any case, some of the applications and indications I'm listing at the bottom there, but you can see mesial temporal sclerosis, callosotomy, SEGAs, focal cortical dysplasia, and a big one I'll be speaking out myself is hypothalamic hamartomas. Next, Keith. So these are just some publications. The literature is becoming quite full. I've been very pleased to have published some of these in the Journal of Neurosurgery, but MR-guided laser thermal therapy is really a rising technology for entities like pediatric epilepsy and also neuro-oncology. Next. So what do you need to get started? As I'm the first speaker, I'll just mention that it's best if you have a dedicated MR, although it can work in other scenarios. I know at other institutions where the MR scanner may be different floor, different away from the operating room, etc. But we actually are fortunate to have an intraoperative MR that we use for the majority of our cases. A delivery system for laser, and there are two on the market, Visualase and Monteris. Navigation is also good, especially the workstation, especially the Stealth platform, which is typically used, at least in our hands. An epilepsy surgery team, since a lot of our cases are brought to us through the epilepsy neurology conferences that we have. And then finally at the bottom, this is not cheap technology, and it does require some financing to get the systems in place. Next. Just some images. May have to go back. Thanks, Keith. So We use the Lexel frame typically, but there are other systems that you could use. We find the Lexel frame is really handy for small lesions where you want complete accuracy, like sub-millimeter accuracy. The Lexel frame is probably the best. Sterile draping, it's not a bad idea before you do your first case to kind of learn the ins and outs of how to drape for a case. The planning station and easy access is mentioned to the MR scanner. Next. So relationship with vendor is key, and we've really enjoyed our relationship with Monteris. I would say no matter which vendor you choose, a relationship is important because systems are a little complicated and there can be some troubleshooting that needs to be done, and we're just not equipped to do that troubleshooting on site at the time of a case. And so it's much better to have the vendors there who can help in the operating room, and we've relied on them heavily, and we have good relationship working with them to solve any problems that may arise. Few as they are, but when you do face one, it's nice to have them in present. Okay, next. So I'll just show you, I have 3 cases total. The first one is a large hypothalamic hamartoma, and these are, I think my colleagues would agree, among the most difficult. And few of you in the on the line, my colleagues in particular, and also those that are attending this webinar, would argue that this large lesion is problematic to treat no matter which type of therapy you would use. So this is a 4-year-old elastic seizures. These are typical seizures that arise from hypothalamic hamartomas. We had tried doing different approaches for this. It didn't seem to be very satisfying. So eventually we chose to do laser ablation. On the bottom, you can see the laser burn that we initially had from this very first attempt. So we did a central region that we targeted. It was a long burn, and the patient tolerated this very well. Next slide, I think, is a video of this laser burn. So Keith, if you can just start the video. And so what you're seeing is the yellow, and if my pointer is active, you can see the yellow and turning to blue, and it represents different temperatures. Yellow being kind of a warning that you're approaching the temperature where there will be ablation. Blue is the temperature, usually around 45, 46 degrees centigrade, that if left for a period of time will definitely cause necrosis. So yellow gives us a good sort of thermography and approach to know when we should be concerned and when we may wish to stop the laser burn. Okay, next. And top panels, you can see 3 months after laser, not much change, but then look what happened 6 months later. Nothing was done in between. So I don't know if my colleagues have seen this before, but it sometimes takes several weeks or months before you get the final outcome. This is exactly what we had planned to do, and so it's quite gratifying to see that in the end, that's what we achieved. But because there was still an attachment on the right and left side of the hypothalamus, we decided to go back in and do a repeat laser burn. So we came back and did an attempt here, and you can see the result at 7 months and at 10 months that we were able to get closer to a more complete disconnection on that right side. Not entirely, but I should mention clinically, this child did a lot better after each of these laser burns. And after a few weeks and months, however, some seizures returned, and so we were trying to get even better coverage, so we decided to come back in. Next slide. And this is very interesting, and this is a problem case for us. We had not seen this before, and I think our Monteris colleagues had not seen this before. But top left panel shows you where we had stopped placing the probe. You can see the tip of the probe, and then typically we stop short of target, and then we advance the probe with the laser, with the robot, which is part of the Monteris design. And when we tried to do that, if you look at the bottom right-hand panel, what you're seeing is that we were unable to penetrate the capsule, if you will, of the hypothalamic hamartoma, but instead the basal ganglia was almost dragged down. You can appreciate that, I think, in the bottom right. So this was, we were kind of oblivious to this at the outset. We couldn't quite figure it out, but in retrospect, this is probably what happened. So in the end, we couldn't achieve the laser burn because of this that we wanted to. We aborted the procedure, having started it and recognizing that we weren't getting nearly the result that we wanted. So it's to show in this case that to be apprised of the situation and try to react to it and not to do something that's going to harm the patient. In the end, this patient did extremely well. And again, even though we did a minimal amount of a burn in this particular case, we're thinking about what our next approach will be, and maybe that can come up in the discussion period, because we have not fully disconnected this large hypothalamic hamartoma to our satisfaction at this stage. Next slide. Okay, so I'm going to talk a little bit about focal cortical dysplasia, and a lot of the lesions we're seeing now are what's called bottom of sulcus dysplasia, and these are sometimes hard to visualize. We have a specially trained MR radiologist, pediatric, who can identify these for us. And you know, we've all looked at thousands of scans, but I dare say some of us, a lot of us, wouldn't see some of these lesions that they can identify. So it's important to identify these. Next slide. And here's what they look like. These are all different cases, and they're very subtle. So they're contained within the yellow circle there. You can see some of these lesions, and just trust me that these are areas of cortical dysplasia. Next. And here's an example of this bottom of sulcus dysplasia. I've got a red circle around, oval around the lesion, which is here, bottom of sulcus. And because it's on both sides of the sulcus, it's an important point here is that the laser won't propagate across the sulcus because the fluid in the sulcus serves as a bit of a heat sink. So you don't get necessarily adequate transfer. So we ended up using two probes in this case. Next slide. And this child had intractable epilepsy. All these children had intractable epilepsy. And just to show you at the time of surgery that the nature of the two implants here, the two laser probes to go on either side of the sulcus to be sure that we had the burn that we wanted. Next slide. And there it is after the burn. Immediately afterwards, you can see we're on either side and we got exactly the type of burn that we wanted. And this child has done extremely well, so far seizure-free after surgery, and we're awaiting long-term follow-up. This is a more recent case, so I don't have 1 or 2 year follow-up in this case, but just to demonstrate that approach of two bolts simultaneously. Next slide. Okay, in my last case, I guess I got this one. Keith, you can play this quickly, but this shows one side of the sulcus and then the other side being ablated by this technology. And the nice thing about the Monteris is it has a side fire laser tip that allows you to burn in basically at right angles to the laser probe itself, which is very useful in many morphologies or configurations of lesions that we face. Okay, next. And then my last case, since I'm just about done, is a giant hypothalamic hamartoma. And this is one, I think this is even bigger than the previous one. So I hope my colleagues would agree these are really challenging, and we haven't figured these all out. Even if you treat these surgically, they're very, very challenging. This is after the laser burn. This is what we got, and this child seizures dropped immediately, not gone completely. This child had underlying Pallister-Hall syndrome, but you can see, and we're planning to bring this child back for a repeat laser burn, probably in the same time frame, 3 to 6 months after this. Next slide. And these are some of the publications on different approaches for hypothalamic hamartoma, whether it's radiofrequency, laser. There are a number of different ways. Open surgery, which I've done. Jim and I have both done endoscopic approaches, but we really find that the laser approach is most minimally invasive and most well tolerated. Next. So the conclusions, it can be performed safely. I talked about the team that's required. Discharge, not for some of those hypothalamic hamartomas that are large, because we keep them in-house a little bit more. We can put them on steroids. But other cases are going home earlier for smaller lesions. Especially, this is useful technology for hypothalamic hamartoma, which I talked about, and cortical dysplasia. Remember the heat sink across the sulcus, and then you can decide which approach you want to use. We're about to get the robot, so we're kind of anxious to put that into play with our laser cases as well. Okay, thanks very much, Keith and Jim. with that, I'll stop and be happy to turn it over to Dr. Drake or whatever you wish to do.
Well, I don't see any questions in the Q&A queue just yet. If there's anybody, a reminder, if anybody does have any questions for the panel, please feel free to type into the Q&A panel or raise your hand, and we'll make sure we try to find some time to get your questions answered. So with that, Dr. Drake, we'll turn it over to you.
Well, thanks very much, Jim. And, you know, Jim Rutka gave a superb introduction and covered a lot of the cases that we've done. So I thought I might focus a little bit on some of the technical nuances and complication avoidance, and particularly for those of you who are get started or haven't started in this area. It is quite a different type of treatment. And I think most of us start out fairly timid in terms of what they're prepared to do, not really sure about what the outcome is going to be. And I would say that the most difficult part of all this is kind of knowing when to stop. And we tend to do these cases with two of us, and you're monitoring, you know, 5 different planes at the same time. So it's often good to have someone else there with you just to, you know, just to provide some advice, because it is complicated. And as we're going to talk about, the heat distribution isn't always what you would anticipate. So next slide, please. So we've done 3 low-grade tumors. We haven't done any malignant tumors, and this is one of them that I thought was quite interesting that we did recently. So this child had previously had a rhabdomyosarcoma of the infratemporal fossa and had been cured of that, but had this lesion in the left peritrigonal area that was growing. We biopsied it, and it was a low-grade glioma with a BRAF 600E mutation, and it was in close approximation to the optic radiations, and it was also calcified. So initially we thought that we would, you know, take this out with a tubular retractor, but the more we talked about it and talked to the family, we decided that we'd use this for laser ablation. But there are a couple of important points to this procedure I want to talk about. So next slide, please. Yeah, so this is the planning station. Jim's talked about this, and this is extremely important. So you plan these trajectories just like you would for an SEEG electrode. And in green, you can see the optic radiations. And this child was absolutely neurologically intact and very worried about any potential deficits. So that was one of the things that was very important. And the other one is that it's right on the edge of the ventricle. And so as you'll see, the ventricle is a huge heat sink. And so, as I said, your heat distribution isn't necessarily what you would think. So we had asked around, and we heard that you could do a calcified lesion, because I was afraid that the laser fiber wouldn't go through the calcified lesion, but as you'll see, in fact, it did. And it was really helpful to import these images into the Monteris system. So we imported the outline of the tumor and also the optic radiations into the treatment system so that we could see what was happening. So if you go to the next slide, and if you just play the video, so that light pink outline that you see there is the tumor, and the light purple, which is below, it's somewhat hard to see, that's the optic radiations. And so this is our first burn here, and Jim talked about the red and yellow, the red and blue lines. And you basically didn't want the blue line to go into anything like the optic radiation, and we wanted to get to the outside of the tumor. So we aimed for the center of the tumor, and you can see on some of the other sequences, I won't belabor this too much, but the heat does not go towards the ventricle the same way it does in other places. And in fact, you can see we're going beyond the tumor more proximally into the white matter, which in this case was okay. So what we did was we persisted with the ablation until we began to encroach on the optic radiations. And you can see that, again, it doesn't show really well, but at the bottom of the screen. So that's when we decided to call a halt. So that's when we stopped. And that, as I said, that's kind of the hard part of the decision making. Next slide, please. Yeah. And so this is what it looked like at 72 hours. You can see there's a fair amount of edema, and I'm going to talk about that in a minute as well. And then he's now 3 months post-ablation, and we are waiting to see how this turns out. It's interesting, our neuro-oncologists are a little tentative, I think, about this, because this is not surgical excision. This is different. From our point of view, it's just destroying it with heat, but we did need to convince our neuro-oncology colleagues to go with this. And we've either biopsied the tumors at the time of the procedure, so you can do that, or in this case, as a separate time. So next slide, please. So this is a quite a small hypothalamic hamartoma in a 3-year-old with intractable seizures. And I just want to talk a little bit about the planning. So next slide. So you can see there, I've got arrows pointing at the postcommissural fibers of the fornix. So you have to avoid these when you're doing the procedure. And so even though you would think there's a wide range of trajectories you can use, actually by the time you account for the optic tracts, the mammillary bodies, these pathways, and the vessels, actually it's a fairly limited number of trajectories that you actually have to the lesion. And so we've had one transient memory disturbance, and that's in a child when we did a giant hamartoma from both sides. On one side, there was no tract that we could see. On the other side, although we missed the tract, there was a little bit of edema near it, and there was transient memory impairment that recovered to normal. So you really do need to spend a lot of time planning these trajectories very carefully and try to anticipate where your heat is going to be distributed. Next slide, please. So this is, again, this is the trajectory on the planning station, and this is a stir image which really shows these tracks quite well. Next slide, please. And this is the sequence here, and you can't see it here completely. I don't want to dwell too much on this, but we outline all the structures that we want to stay away with, because on 3 planes, they're non-anatomical planes, and so it's hard to stay absolutely oriented to where exactly you are. I mean, the 3 planes on the bottom are orthogonal, so you get a better idea. But we outline the optic tracts and the mammillary bodies and the midbrain and anything else that we're really interested in staying away from, and use those as boundaries. So we either import them or we outline them in the time of the procedure. Next slide, please. Yeah, next slide. Yeah, so this is at 72 hours, and we used to send these kids home the next day because they looked great. But actually, this edema takes about 72 hours to develop. And this child was completely asymptomatic, but I have a better example coming. But there's a lot of edema actually in the optic tract, even though the blue line didn't really encroach on the optic tract. And you can see our burn has gone back also into the hypothalamus to some degree. And there were actually no symptoms about that either. And this looked to us like a complete ablation of the hypothalamic hamartoma, and the seizures stopped for a month, and then they have come back. So I don't think we totally understand what, and particularly in the giant hypothalamic hamartomas, what actually we need to ablate in order to get seizure freedom. And for some, and I'd be interested in the other panelists' comments, it's been somewhat unpredictable what the response is going to be. Now, I'm just going to talk a little bit more about the complications. So this is another, we've had a lot of these giant hypothalamic hamartomas, and at the top left is where we started, and after the second one, second top right is after the first burn, and then on the bottom 2 slides are the post-second ablation. And this child had, I think, our most significant transient complications. So he was 2 years old. He had SIADH. He was quite somnolent for almost a week. And he developed this edema that was, at the time, this is the first time I'd encountered this, and this is, I said, at 72 hours. But if you look on the bottom right, he has edema in his optic nerves and chiasm. And if you go to the next slide, that's the burn. I just want to do the burn for 1 second because I just want to show you. So here we're using the directional fiber. So this is the 3.2 millimeter probe, and it's directional. And you can see an arrow in the middle in a second. So there's the arrow. So right there, actually firing right at the optic tract in the top middle frame that you saw there. And you then see us, as we approach the optic tract, we then swing the direction of the fiber in the opposite direction to deal with other parts of the hypothalamic hamartoma. So the directional fiber, the directional component of the fiber is useful in order to deal with unexpected heat sinks and also to stay away from areas that you're concerned about, such as the optic tracts and other things. So next, so this is the second burn. And so the next slide, please. And I think, yeah, okay, perfect. So I'm just showing the edema at 72 hours. And so you can see it's in the hypothalamic hamartoma, but it's also selectively in the optic tracts. And it goes way back. And I don't know, I'm not sure why this happens. I mean, when we do the cortical lesions that Jim says, it doesn't seem to fire any particular pathways. This child had absolutely no visual impairment whatsoever. And the hypothalamic dysfunction improved, and he's almost seizure free. And at the bottom right, this is post-second ablation. And as Jim mentioned, you can actually remove with the laser a large part of these hypothalamic hamartomas. So just in the next slide, please. So I just want to finish up with basically just kind of prompting others to maybe get involved in this, because I think, you know, this therapy works extremely well, but it's somewhat unpredictable. And so we're not the first ones to say that, you know, modeling the heat distribution would be really advantageous. So there have been some reports on this in terms of modeling for MR-guided LITT, and I've just showed a couple of them here. And if you just go to the next slide, I just want to talk a little bit about what we've been doing for focused ultrasound. So this is not for MR-guided LITT, but we've been trying to develop modeling systems for heat distribution in a variety of tissues, including the brain. And here I'm going to show, that's great, I'm going to show liver and kidney, but you know, the brain is also a soft tissue. So this is the kind of system that we're developing, and we're using this Pen's bioheat equation, which is from 1948. And here we are with our our focused ultrasound setup and heat map. Next slide, please. And this is what it takes in order to do this on the fly. So this is using parallel processing in order to map the heat distribution almost in real time. And I think this is almost what it would take in order for this to work really well. Next slide. And so this is, you know, this is a graphical user interface. And the next slide. And these are the kind of modeling that we can get using focused ultrasound, but the laser is very similar in how it's a point source of heat, basically, and it can be directional. And these are examples of our experimental, our simulated, and the thermometry. And so you can get a model that's reasonably approximate for things at this stage, which are still relatively circular. Next slide. And this is an example of the simulation above, and the bottom is the real heat distribution on MRI. Next slide. So I'm just to briefly summarize. I think this technology is great. The planning is extremely important. This post-ablation edema is significant, and you need to account for it. And we're treating the patients longer pre-op with steroids and longer post-op with steroids. And I really think that better simulation, I think, would really help us improve our ability to select, do the trajectories, and plan for the thermal treatment. So thanks very much, and I'll stop there.
Great, thanks, Dr. Drake. Great overview of the sick kids experience. We got a little bit of time. Maybe I'll just open up to the panel. Any questions about Dr. Drake or Dr. Rutka's talk here thus far?
I'll make a comment. So I have not treated a hypothalamic hamartoma with laser yet. I actually have one scheduled next month. And I sought some advice from Dan Curry, who's done over maybe 100, 150 of these. And he taught a master class on this with a global epilepsy surgery conference that we do monthly online. And one thing that he mentioned that might be helpful is he actually pre-treats these patients with high-dose steroids for like 10 days prior. That might help with those post-operative edema problems.
Yeah, no. So we haven't gone quite to 10 days, but we have started pre-treating them much more aggressively. Yeah.
And then actually I have scheduled, he's offered just to do the planning with me virtually via Zoom. So I'm going to have him come to St. Louis via Zoom and plan it's a really tiny hamartoma, really down low, in a kid who failed radiosurgery and continues to have progressive seizures and developmental stagnation. So I think the only option for him really is the laser ablation at this point.
You mentioned this, Dr. Drake and Dr. Smyth. We get this question a lot from our user base relative to steroids usage. What's the typical course post ablation for sort of a steroid treatment at sick kids?
Yeah, so as I said, initially we were giving like a couple of doses and discharging the patients the next day. You know, we thought this was amazing. And then as I said, since we've had a couple of these cases, and particularly that's been the larger ablations and in that region of the hypothalamus, and that we have been pre-treating them pre-op and then treating them post-op for at least 5 days. And then if there's any symptoms whatsoever, extending that up to a week or more. So I don't know that you can be too aggressive with the steroids, especially for the ones that are in the hypothalamus and for the ones that are, particularly the ones that are large.
Great.
Oh, Taylor?
Anything else?
What about you, Taylor? I think you might be muted.
Yeah, sorry about that. I haven't started pre-treating, but we do, for every ablation, we do a week of 7 days of steroid taper afterwards. We found that helps a lot. I actually had a question for the whole panel. How do you manage treatment failure after laser ablation? How long do you wait before getting another scan, and how long do you wait before trying either another ablation or a resection or some other type of treatment?
Yeah, thanks, David. For the hypothalamic hamartomas, we will wait, as I showed in my presentation, for the large one, where you might have to wait 3 months or more to actually see the end result of your laser burn. So we probably would wait till then, and usually have a bit of time to decide. And then one of the big problems, and Jim mentioned this, is figuring out the morphology and the attachments, essentially, of the hypothalamus to the hamartoma, and trying to disconnect in 3 dimensions is not a trivial thing. And we think that that's probably why there are failures. And if you can go circumferential around the attachment site, then that's optimal, but it's easier said than done, I would say.
Great. We do have one other question sort of along the same lines from the audience. What is the typical size of burn where you typically see severe edema?
Yes. So you get it. I think you get edema with any burn, I would say. And the larger the burn, I would say the more edema you get. So if you're completely within the hypothalamic hamartoma, it probably doesn't matter. But if you are actually doing the disconnection, then and you're up against the hypothalamus, I think it's proportional to the size of the burn is my, and I don't have we don't have nearly the experience of Dan Curry, obviously, but that would be my take on this. So smaller burn, smaller amount of edema.
Great. And then maybe one last question before we move on, Dr. Drake, because you talked a little bit about the heat sink effect. One of the questions here is, I understand the vessels act as a heat sink, but is there any risk of injury in the vessels, i.e. pseudoaneurysm or et cetera?
Yeah, so we worried about that, but because the blood is flowing so quickly through the vessels, they just take the heat away. So they're actually relatively immune to this heat, it would appear. And we haven't so far seen any type of vascular injury. But and as Jim Rutka talked about, the depth of sulcus lesions, and you're basically often trying to fire across the sulcus to the other side with the laser, and the vessel actually kind of gets in the way to that extent. And that's why Jim was talking about sometimes you can require 2 probes on either side just because of the vessel acting as a heat sink. So at least on one occasion, we've been able to go across for a smaller depth of sulcus lesion. We've been able to go across the sulcus through the vessel, and we were able to do it with the side fire laser, and we didn't injure the vessel. But it's a good question. It's something that we were concerned about to begin with.
Great. Well, maybe in the interest of time, Dr. Smyth, we'll turn it over to you.
Thanks. So you can give me control of the slides. Yeah, looks like you are. So I'm honored and humbled to be on this panel talking about this, but we're all still pretty new to laser ablation and all kind of learning together. The setup that I have in St. Louis is the Monteris NeuroBlate system is in our adult hospital, Barnes Hospital, connected to our children's hospital via a bridge. It's set up in an intraoperative MRI suite. And that was the first laser ablation system we had. We've been using it in children since about 2015. At the Children's Hospital, we have the Visualase system with a diagnostic MRI scan. So the workflow at Children's is we place the fiber in the OR, and then we transfer the patient down to the MRI scanner to do the ablations there. I selected 4 cases. I was asked to focus on tumors. I'm more of an epilepsy guy, so you'll see that all these tumors have an epilepsy flavor. The first case is a SEGA. This is a kid with tuberous sclerosis, and the Monteris gets you bigger lesion volumes, so I tend to choose the Monteris in kids, even though I have to take them to the adult hospital when I want to target a larger lesion. This was he was 2 years old at this time with the lesion, and it showed some steady, slow growth over time. So he had not really developed symptomatic hydrocephalus, but with a little bit of ventricular enlargement and linear growth, we recommended treatment. We selected to do laser ablation. He had a global developmental delay. And then this is how we approached the fiber. We went in through the ventricle from above. I would warn those that are attempting SEGA ablation that the SEGA can swell after the procedure and can obstruct the foramen Monroe. So in these cases, I'll often leave a ventricular catheter behind after the ablation, just in case there's obstruction, or at least monitor those patients closely in case they swell. This was his post-op imaging at 6 months. So this really had, even though we had a nice ablation going out to the margins, and the margins are nicely capped by the ventricular CSF, we did not get a good reduction in size, even following out for 12 months. Now, we did arrest the growth, but we did not get shrinkage of this lesion. And here he is out at 24 months. So I'm continuing to follow this child. He also has some seizures and some tubers, but right now he's clinically stable and progressing along. This was the first one that we treated about 5 years ago. And here we saw a very nice reduction in SEGA volume after the ablation. So there are some mixed results with the SEGAs. I've treated about 7 or 8, and I'd say about 1/3 of them don't seem to shrink, and about 2/3 of them shrink dramatically. That's my small personal series. It's not published. I think there may be some variation within the SEGA in terms of calcification that might affect the heat delivery, but I think there's still a lot to learn about this lesion with laser. The next case is a child. He was 7 years old at the time of his ablation. He had this lesion in the occipital lobe, which I'll show you in a minute. He was neurologically intact and had this area of presumed low-grade neuronal glial tumor or maybe dysplasia that at the time was non-enhancing. And then as we followed it over time, you can see the T2 lesion. It developed some new enhancement. And this, along with some worsened focal seizures with a visual component, prompted an intervention. And so we offered a biopsy and ablation at one setting using the Monteris system. He had failed medications, refractory, of course. So we targeted this with 2 adjacent laser fibers. Since 2016, I've been using ROSA for both the Monteris ablations and the Visualase ablations for my stereotactic guidance. So I do all of my planning on the ROSA platform, which I'm familiar with for the SEEG, and then we can use that for placement of the bolts and the fibers. This resulted in a nice ablation of the zone. Here is our 3-month scan, 6-month scan. This is lagging a little bit, it's not advancing. And then here we are out at 3 years with a nice shrinkage of the lesion. We placed the biopsy needle after placing the bolt, and there is some risk of causing a little hemorrhage or introducing a little bit of air, which can affect the thermography and the ablation. So I think there is some value to staging a biopsy, but when we do need tissue, I've been tending to do it at the time of the ablation and haven't encountered too much difficulty. He is an Engel class 1 seizure free, but he does have a visual field cut, which he was counseled to anticipate with this ablation. Another view of the ablation. So this was a more recent patient that we tackled last year. He's 12 years old. He had an interesting history in that he, as an infant, suffered a perinatal parenchymal hemorrhage and underwent a craniotomy and a resection of a large region or a large lesion with some adjacent encephalomalacia that developed. That was done remotely at another institution. And he developed refractory epilepsy that had a right-sided component on his non-invasive studies, but he also developed this lesion back here adjacent to the cingulate in the deep parietal lobe. And this had been demonstrated to grow over time. And while his seizures seemed more frontal, he had developed this lesion incidentally, and it being adjacent to his limbic system, we postulated that it might be part of a seizure network. So we set out to do a ROSA-guided Monteris biopsy and laser ablation with a single fiber using the Monteris system. So show you his ablation. He had a normal exam and frequent seizures. I can go through all the details here. And we planned a single trajectory behind the Rolandic cortex through the superior parietal lobule to approach this lesion, and did a single run of ablation with the fiber getting out to the margins. Here's the yellow and blue zones showing the ablation. I treat these with high-dose steroids for 48 hours and then a 1-week taper. Patients like this, I send home the next day. If there's a smallish burn intraparenchymal, I'll send them home the next day. If it's a large 2-fiber burn with a large region of potential edema, I'll keep them in the hospital. Or if it's periventricular, I'll keep them in for observation for a longer period. So here's his post-ablation imaging. Unfortunately, he continued to have seizures, so we took him back last fall and did a frontal disconnection, and now, at least for the past 3 months, he's now been rendered seizure-free. The final case I'll present is a pure epilepsy case. This was the first time we used the laser system for callosotomy. I had been looking for the right case. This was, I thought, a good case back then to try this on. This is a patient who had undergone an anterior open disconnection for her Lennox-Gastaut syndrome and drop attacks. And she continued to have a lot of drop attacks, and so her epileptologist requested a disconnection of her splenium. So it being just a small remnant back here, we thought this was an optimal case to try out the laser ablation. I think at this time, maybe 1 or 2 case reports had been out there demonstrating this was possible. So similar to that pericingulate deep parietal lesion, we did an approach through the superior parietal lobule, single fiber ablation, getting the fiber within the splenium, and did the disconnection that way. And here's the post-ablation imaging. This is at day 1. You can see the edema creeping out along the forceps major. What we've moved to now is doing 2-fiber anterior 2/3 callosotomies and 3 or 4-fiber complete callosotomies. The majority of the laser callosotomies that I've been doing have been with Visualase, in part because it's at our pediatric hospital and it's the system that's right here, and in part because they're smaller fibers, but either system is amenable to these white matter disconnections. I think Taylor might have a callosotomy case to show as well. The nice thing is, instead of doing the open craniotomy, you can get the laser fibers in minimally invasively, and you've got these natural heat sinks. So you get conformal burns. As long as you get the fiber within the callosum, the ablation will conform to the dorsum and the ventral surfaces of the callosum. And you don't have to be straight midline, of course. You can work from right to left or left to right. And as long as you're cutting the callosum somewhere sagittally or parasagittally, you're going to get the effective disconnection. And then in terms of entry points, I tend to do one near the hairline to get the the genu and the rostrum, and I do one near the eyebrow to get the body. And here's what a couple of the fibers, these are visualized fibers, but you can do the same thing with the Monteris fiber. So I'll often try and target off the frontal sinus using a little eyebrow incision. I make a little 4mm incision and close it with a single suture and some dermabond. And the scarring is pretty minimal. And so the patients, I usually send these kids home after about 2 or 3 days. I think that was my last slide.
Great, thanks, Dr. Smyth. Any questions from the panel?
Yeah, say Matt, that's great about the corpus callosotomy cases, and just wondering, have you followed these cases long enough? Has anyone done enough of these to actually see what the scans look like and follow up, and how complete you get? Because it's a pretty complicated geometry, the corpus callosum, and if not, what are the hardest regions to reach, and how do you troubleshoot those?
Yeah, there's a couple questions wrapped up in there. So completeness of disconnection is an issue. If you do an open callosotomy, you know you can get front to back. You can see the peel playing over the vein of Galen. You know you've disconnected it. With the laser, it's probably not 100% disconnection. There are some residual fibers. People have used and published on DTI, but really for me, it's looking at the post-ablation T1MP range and just scrolling back and forth. And you can kind of three-dimensionally visualize each segment of the callosum and confirm that you've got it all.
Right.
And then in terms of follow-up imaging, most of these kids, there's not a clinical need to re-image them after the procedure. Either they've had a response or they haven't. And those that are non-responders, we do re-image them, and we'll do a second stage ablation in selected cases if the family's motivated to do so. We've done about 17 or 18 with laser right now. I happened to see one this morning. His drops are completely gone. He's 6 months out. And I happen to be planning right now one that's being, recommended callosotomy for drops. So I think in the next couple of years, we're going to be able to answer that question better. But so for right now, it seems like the efficacy is similar to open callosotomy in terms of seizure control for drop seizures.
And what about hemispherotomy? Do you think that's coming down the pike?
Well, I mean, I think it's here. People have done it. I think for hemispherotomy without a lot of tissue to burn, you can do completions. And I've touched up a couple of incomplete white matter tracks on hemispherotomies using laser. Yeah. But I think trying to do a complete hemispherotomy, for example, on a hemimegalencephaly patient, that's 10 fibers, it's 15 hours. Everyone has some risk with it, a lot of edema. Personally, I think that's probably a bad idea.
I think so, yeah.
So one question we did come in, Dr. Smyth, or anyone else on the panel, was sometimes after open callosotomy, these patients can get some leg weakness post-op, even without retraction. Have you seen this after laser ablation at all?
Yeah, I have one case that I cut the slides for brevity's sake, but my one complication associated with laser ablation for callosotomy was very interesting. It's a kid who blossomed a hemorrhage in the supplementary motor area that was not present at the time of the ablation during the scan or during placement. So it must have occurred with withdrawing the fiber, because it occurred, it wasn't occurring during the ablation scan, and on my routine post-op day 1 scan, I saw it. So he developed an SMA syndrome associated with a intraparenchymal hemorrhage with withdrawal of the fiber. He had a complete resolution and a good recovery. But that's the only time I've seen a hemiparesis after laser. But we certainly see that with frontal lobe retraction, venous ischemia with open callosotomy. In my hands, like 15 or 20% of the time, there's a transient hemiparesis. So that's one advantage of the lasers. We don't seem to see that.
Great. Any other questions from the panel? Otherwise, Dr. Abel, we'll turn it over to you and to finish up.
Right. Thank you for inviting me to the panel this evening. I should be able, just in the interest of time, I should be able to get through these in about 9 minutes. Next slide. So I just wanted to go through a few of the cases that we've done here. This is an 11-year-old boy with a history of non-accidental trauma who had a hemicraniectomy and then titanium mesh reconstruction with drug-resistant post-traumatic epilepsy who was on multiple medications. He had a right hemiparesis. He's had 3 previous cranial surgeries, including a wound infection. And I just mentioned that to illustrate the complexity that a redo craniotomy would have for this patient. And he had a phase 1 evaluation that suggested a temporal lobe epilepsy. And so he's referred to me for consideration of VNS or phase 2 evaluation. We can go to the next slide. And so you can see on the left side, the family ultimately elected to have a stereo EEG evaluation. And you can see on the left side of the screen the schematic of areas we explored with stereo EEG. And ultimately what we found was that the seizures originated from the mesial structures with late spread to the temporal neocortex. And so we offered the patient a mesial temporal ablation. You can go to the next slide. And so you can see here the ultimate ablation outcome. This is an acute scan. And he was seizure-free at 1 year, but unfortunately, we just found out that he's been having seizures. So we're considering additional therapy for him. But this is a case where, given the history of cranial surgery, we probably would have considered a laser ablation, even if there had been rapid spread from the hippocampus, given the complexity of doing a redo craniotomy for this patient. Next. This is another temporal lobe epilepsy case that I wanted to show just because this is a patient that we would not select for mesial temporal ablation. This is a 9-year-old boy with drug-resistant epilepsy and right mesial temporal sclerosis. This is a patient where the semiology, even though he had mesial temporal sclerosis, was not consistent with a mesial temporal lobe epilepsy syndrome. And so our pre-implantation hypothesis was that there was a neocortical temporal lobe epilepsy. Next slide. And so the left shows a schematic of the SEEG exploration we performed. This is a patient where there was simultaneous onset in temporal polar cortex and the hippocampus. And so we performed an anterior temporal lobectomy. There's no actual evidence that you can't try a mesial temporal ablation in these patients, but this is a situation where we've been going straight to open surgery rather than a mesial temporal ablation. Next slide. This is a callosotomy case, a 6-year-old girl with Lennox-Gastaut syndrome who's having 20 to 30 seizures a day, half of which were atonic drop type seizures. She was on 4 different medications and again was referred for vagus nerve stimulation, but given the frequency of atonic seizures, we discussed performing a laser callosotomy at the time of VNS implantation. You go to the next slide. And so these are similar to what Dr. Smyth has published, and I can say I referred to Dr. Smyth's publication when I was planning this case. These are the trajectories we planned. I actually did a laser callosotomy this morning, and this is typically what we've been doing when attempting a complete callosotomy, 3 or 4 trajectories, one that targets the genu, one that targets the splenium, and then another anterior trajectory that goes through the forehead that targets the body of the corpus callosum. I have not done an eyebrow incision, but I find that if I use a subcuticular stitch after going through the forehead with the drill, the scar is cosmetically okay. Next slide. So this is our setup. I use bone fiducials for registration. I'll put in 5 bone fiducials and then do an O-arm spin, which we co-register to our preoperative plan on which we do with the ROSA software. You can see here in this picture that we're using the Atama board. I've switched from using the Atama board on some cases to using the Lexel frame on every case, just because I think the co-registration with the ROSA software is more straightforward doing that, and also there's more versatility with the robot. On the right, you can see a picture of a different case where we used 4 trajectories for a callosotomy. That's a separate patient. You can go to the next slide. And why don't you go ahead and play the video? And you can see here that we're able to get almost all of the corpus callosum, but you can see that, and I don't think my mouse is showing up here, but there's a small part in the posterior aspect of the body where we were not able to achieve a complete callosotomy. But go to the next slide. But this is a patient where it didn't matter. She left on post-op day 3. She did require a temporary rehabilitation admission. She's had no atonic seizures since surgery, and now she also has some days without seizures. And so she's had a clinically beneficial outcome, and we're continuing to monitor her. She's now about a year out. Next slide. This is a patient with insulo-opercular epilepsy, and this will be the last case I show. This is a 14-year-old girl with a history of hypoxic ischemic injury after birth and drug-resistant epilepsy. She had 6 or 7 seizures a day, was on 3 drugs, and you can see that she has a extensive lesion posteriorly on both sides. Next slide. We performed a bilateral stereo EEG implantation focusing on the posterior cortices and also the insula. Next slide. Her seizure onset zone was in the insula and in frontal operculum, and so we performed a 3-trajectory ablation of the insula-opercular region, and she's been seizure-free since then. And she's a patient where, because of her comorbidities, she also was morbidly obese, would probably not have been a good candidate for a traditional craniotomy. And I think that's it. Next slide. That's it. Thank you very much.
Great. Thanks, Dr. Abel. Any questions from the panel?
Taylor, what's your plan with the failed mesial temporal laser ablation case that just started seizing?
So we're planning a redo stereo EEG evaluation. We've not discussed this patient in conference yet, but that's the informal discussion we've had so far. I think if I would probably do a traditional temporal lobe resection with a plastic surgeon to do a med por or cranioplasty.
I've done one redo temporal lobe resection after a failed laser ablation, and it was a difficult operation because the temporal horn disappeared. It just got glued shut with adhesion. So I lost a lot of my typical anatomic landmarks. So it was actually kind of a anxiety-provoking resection. Ultimately, he did great and was rendered seizure-free after the initial ablation. He failed right off the bat, and even though the burn seemed to envelop the majority of the amygdalo-hippocampal complex, his post-op scans show that there still was an outer circumference of residual hippocampus that didn't get ablated, even though the thermography and the algorithms suggested we had gotten it all.
I have one patient who's done well after a redo mesial temporal ablation, and this is a case where it's very tempting to do that, just to see if it works, given the morbidity of doing a redo craniotomy.
Yeah, given the difficulty of the mesial resection and your craniotomy defect, maybe repeating laser would be reasonable.
Taylor, with the SEEG cases, and then where you decide you're going to do a laser ablation, how do you stage that? Or do you think if you had the technology, would you do it all at the same time?
Yeah. So I think, in Grenoble, we were able to do thermocoagulation in these cases, which I thought was really nice. It doesn't give you as controlled or large of a lesion, but it gave you some feedback on whether or not the sites you were targeting for ablation might result in seizure freedom. There can be some localizing value with the thermocoagulation. And the other benefit of thermocoagulation is you can record afterwards. so there are some situations where we do the recordings and we just know right away that an ablation is a good idea, and but just logistically with OR scheduling, we haven't been able to just, at least at our center, haven't been able to do ablations at the time of electrode removals. Just to save OR time, what I've been doing is just taking out electrodes on call as soon as the patients have seizures, and then scheduling ablations later on. So there are some of those barriers, but anyway, so I've kind of, our series is a mix and mash of doing those different things, either acute ablation or waiting about 6 weeks. What have other people been doing?
I've used hybrid bolts a couple of times to do the SCEG, then swap the fiber in without having to place the fiber with new stereotaxy. But most of the time we're just pulling the electrodes out and then taking our time to schedule it electively, which from a practical standpoint is so much easier than trying to squeeze in your second stage during that first hospitalization. It can be hard to get it done. And you need the MRI scanner availability and all those things, which is a very finite resource. How about up in the Great White North?
Same. We do the same thing as you do, Matt, as you described.
So one additional question that came in, for the corpus callosum ablations, could you do a posterior trajectory to the body of the corpus callosum instead of going through the forehead? Any thoughts, Dr. Smyth or Dr. Abel?
Yeah, I started doing that, and if you actually do the measurements, it's about 2 to 3 centimeters longer, and you need to be spot on. If you miss the callosum, you can't do the ablation. If you're an intraoperative MRI scanner, you can check that. If you have to move to a diagnostic MRI scanner, you kind of burn that bridge. You have to go back and reposition. And so I learned the hard way. Actually, in the paper I published, I showed a case of a posterior trajectory, and it threaded in and out of the callosum through the through the septum pellucidum and went back in. So it was an incomplete burn. So it's just a shorter trajectory to go from the front. And like Taylor said, we do a little 4mm stab incision. If you can't get it in the eyebrow, you do it in the mid forehead. It heals beautifully. It's like a little tiny, it looks like when you pin them, it's a little pock mark. So.
The other thing I would mention is with the longer trajectory of a posterior approach, you may have to use 2 different length fibers. And so you can save, I think it's like $10,000 or something if you're able to keep your distances similar enough to use 1 fiber.
Great. So maybe one final question to wrap it up to the full panel. As I know we've got some newer users to laser ablation in the pediatric space on tonight. What would be your advice to them in terms of, as they're starting out? We had a nice hybrid mix of approaches for laser ablation. Where would you guide people to sort of begin their experience with laser ablation, especially in the pediatric space? Maybe Dr. Abel, you want to any thoughts?
Yeah, I think I think all these cases have different nuances, and I think the most important thing is just reaching out to people that have done cases like this before. I think everybody on this panel would be amenable to receiving questions from other people that are getting started. But I think mesiotemporal cases, there's a lot published on those, and so those are good cases to start with. Any other thoughts?
Any thoughts from anyone else?
Yeah, we actually had colleagues who had experience with laser come to our operating room as we were starting out and giving us, direct advice on the day of surgery, and that seemed to help. After you do it once or twice, you're pretty much launched and you're ready to go.
Yeah, I'd also say that the support provided by the vendors is outstanding, with both systems. So they really can be very helpful to rely on. I was lucky though in that Eric Luthart, who had started using it, he's the very first user of this technology. So he proctored my first 5 or 6 cases. So he was, right here in town. So I had the benefit of his experience to guide me through the first few cases. But in terms of selecting cases, yeah, pick ones that take a single fiber, small lesions. Don't try to tackle big, complicated, complex lesions with multiple fibers. It's too complicated. And in terms of targeting, you need to be accurate. So whatever system is going to maximize your accuracy.
Yeah, I think the support by the vendors is critical. I mean, the engineers with the companies are extraordinarily knowledgeable. And we actually were faced with the option during the lockdown and when the border was closed about whether or not we would get this done remotely. And we're a little leery of that, actually. I mean, maybe we'll get there, but it's a very sophisticated system and you really have to understand it very well in order to use it. So their support is critical, especially for the first several cases. They're very knowledgeable.
Great. Well, look, we're just past the top of the hour. I wanted to take one last opportunity to thank each of our panelists tonight. Thank you all. We're really grateful for you finding some time this afternoon to share your experiences with the panelists. And thanks everybody for joining. And we're hoping this you found this evening beneficial.